on the from acute to chronic heart failure, guideline-directed medical therapy during COVID-19 pandemic. And the whole section will be opened and chaired first by President of the Asian Pacific Society of Cardiology, Dr. Dr. Jack Tan. So Dr. Tan, please.
Thanks, Prof. Lin. Again, I first like to start off by thanking personally Professor Lin for his vision. Sorry, before I start, can I get everyone to be muted first? For those who are not muted, especially Prof. Lin, your side, I think. Maybe I get your speakers to be muted. Thanks a lot. So it's 11 a.m. Just a date stamp is the 5th of August, 2020. We are in the midst of our APAN Congress. Firstly, I'd like to thank my co-chair, Professor Lin, for his vision in starting the APSC Cloud platform in conjunction with APSC. My co-chair for today, other co-chair is Professor Yeo Koon Keong from National Heart Centre, Singapore. He is the scientific chair for APSC. Today, our program is going to be an exciting program. It's APSC Cloud Heart Failure Forum, from acute to chronic heart failure, GDMT during COVID-19 pandemic. We are going to talk about heart failure, but we want to see how acute and chronic heart failure is treated during this period of a pandemic. I would like to quickly introduce the first two speakers before the Q&A session. The first speaker is Dr. Julian Kendrick Low, a consultant cardiologist and our coronary care unit specialist at the National Heart Centre, Singapore. His focus is in advanced heart failure and critical care. The second speaker is Dr. Chu Kai Wu, staff cardiologist at the National Taiwan University Hospital. He has a research interest in HFpEF and the molecular mechanism of cardiac diastolic dysfunction. He did his MD, Masters, as well as PhD at NTU, followed by a postdoc training in Stanford University. So very two esteemed speakers. They are going to address both acute and heart failure management during COVID-19 pandemic. So without further ado, I would like to have the first speaker, Dr. Low, screen share his slides. And his talk today is the strategy of acute heart failure therapy during COVID-19 pandemic. Dr. Low, please.
Thank you. Sorry, let me just try this out. Sorry, I'm having some trouble sharing the screen.
No problem. It happens. Can I ask whether Dr. Wu is ready to give his talk first? We can switch track and go to chronic heart failure during COVID-19 pandemic first. Dr.
Okay,
Wu, are you ready?
Yeah, it's okay for me.
So maybe you can screen share your slides first.
Okay.
Then while Julian sort out his end. Is that okay with you, Julian?
Sure. Sorry about this.
No problem. So Dr. Wu, you want to share your slides first? So Dr. Wu's talk is on chronic heart failure management during COVID-19 pandemic. Is there going to be any GDMT changes that will vary from the best practice guidelines? Dr. Wu, are you able to screen share?
We're ready. One moment.
So Dr. Wu will go first for the chronic heart failure management. Okay, the screen share is up, so he can start.
Okay.
Thank you.
Hello, everyone. Ladies and gentlemen, and the dear Mr. Chairman, and I'm Dr. Cho Kai Wu from National Taiwan University Hospital. It's really my honor to have the chance to share the strategy about chronic heart failure management, especially during COVID-19 era. Is there any guideline-directed medical therapy change? As we can see from these pictures, and we are realizing that the cases of COVID-19 infected cases are still in growth. So we cannot anticipate the early terminations of the pandemic in recent days. So what we have to do about chronic heart failure treatment is to find a way to adjust a better treatment strategy for all the patients under chronic heart failure, because we can anticipate the disease to prolong, and we have to make sure is our current treatment adequate for all the patients, because they will have to face the pandemic for a relative longer time than we have previously anticipated. So this is the current condition in Taiwan about 2 months ago. Even up to yesterday, we have only about 475 cases with infected by the COVID virus, and only 7 days in Taiwan. It's not a large amount of patients with infections of the disease. However, the medical conditions has already been changed. Patients with chronic heart failure, they are not willing to come to the hospital because they are afraid of further infections because of the pandemic era. So they are willing to take so-called telemedicines, or they are willing to get a medicine only to take the medicine by themselves instead of visiting the hospital. So it's really that the medical conditions has been changed, and we need to find a way to better treat the chronic heart failure. And we are going to make sure is our current GDMT therapy adequate for these chronic heart failure patients. So first of all, we like to know the association between chronic heart failure and the COVID-19 infection. These pictures provided the information by the American CDC about 2 months ago. We can see here patients with cardiovascular disease only take account for only a small portions for the confirmed COVID-19 cases. However, if we turn to the cases with mortalities, the percentages of cardiovascular disease increased to about 18%. And this can imply that patients with underlying cardiovascular disease, although they are not take up account for the chance to get infected by the virus, but if they are not treated well for their underlying disease, they are prone to higher risk for severe disease and even to mortality. So what we have to do is to control the disease well. So the GDMT therapy not only to be offered by the patients, but we need even to more aggressively treat these patients by our current GDMT therapies. This paper was published in JAMA Network in March, and they enrolled about 645 cases, and the authors concluded that patients with cardiac injury have about 10 times higher mortality rates comparing to those without. And for patients with chronic heart failure, they have 8 times higher mortality rates comparing to those without. And the following paper just published in May in New England Journal of Medicine also concluded that the top 1 and 2 risk factors for mortality in COVID-19 is just chronic heart failure or coronary artery disease. If patients tend to have chronic heart failure, they have a chance about 2.5 times for the prone to mortality than those without. And the further papers published in New England Journal of Medicine also provided us information that if patients have chronic heart failure, they have a chance of 16% mortality rate, which is a very high percentage to be prone to mortality. And all these informations just imply us we have to control the disease even better in this pandemic era, because if the patients were not well controlled for their underlying chronic heart disease, they have an even much more higher rate for mortality comparing to normal populations or comparing to patients with the same characteristics. This is how COVID virus may cause myocardial injuries. We can see here with invasions of the virus itself could produce the injury to the myocardium and leads to decompensated heart failure, acute coronary syndrome, myocarditis, or other bad conditions for the heart. And through other mechanisms, as we provided here, here is a schematic shows provided in the Lancet papers. You can see here the COVID virus can invade through the receptors, and it could produce informations with the response of the host. this inflammation response could produce plaque ruptures and lead to acute coronary syndromes, and it could also lead to the development of myocarditis. All these factors, with the accumulations of all these factors, patients could suffer for about a 20% rate for the development of heart failure. And with the development of heart failure, they have an even higher percentages to further worse prognosis, such as mortality. So all this data, all these informations have provided us a hint that we need to do more for our current GDMT therapies, not only to think about whether we should do or not, but we should even do more aggressively treatment for our current GDMT. We should treat our chronic heart failure patients even better to let them to have better protections under this pandemic era. But there left us another concern for us, because we all know that the virus could invade myocardium through the ACE receptors, the ACE2 receptors. The SARS-CoV virus just went into the host through these receptors. And however, the ACE inhibitors or angiotensin II receptor blockers we are using now tend to increase the amount of ACE2 receptors. So experts would be worried that if we are keeping using these agents, would we provide higher chance for the patients to be prone to be infected by the virus? So will the chronic heart failure patients have higher chances to be infected by the virus? However, if the patients are infected by the virus, the virus would cause the downregulations of the ACE2 receptors, which would lead to overexpressions of angiotensin II. These overexpressions would lead to further development of coronary artery disease or further worse prognosis of chronic heart failure. So in these circumstances, we have to enhance our usage of angiotensin II blockage or ACE inhibitors. So these two mechanisms just tend to be conflict. We have to decide whether to use the ACE inhibitors, ARB, or not. So we have to see more evidence about GDMT and the COVID-19. More specifically, we would like to know, is ACE, ARB, or ARNI safe in COVID-19 patients, especially for those with chronic heart failure? Because there are two possible pathways. ACI or ARB could lead to enhancement of ACE2 and probably enhance the binding of SARS-CoV virus and leads to worse outcome or the incidence of infections of COVID-19. On the other hand, ACEI or ARB could lead to enhancement of ACE2 receptors, and this enhancement could reduce the inflammations that the virus may bring and may cause less fibrosis once the patients are infected by the virus. So we need to see more evidence. These early papers published in February enrolled about 70,000 patients tested for COVID-19 in New York. And overall, about 4,000 patients had hypertension, and even more than 50% of the patients were positively selected by the virus. So these are the characteristics of these the cases and the controls. Patients with hypertension is about 4,000 in amount, and most of them are receiving ACI or ARB. More than 50% of the patients with hypertension are receiving ACE inhibitors and ARB. And after the adjustment of the patients and the control means those without infected by the COVID virus. We could see here are the summary of all the medications used in all hypertension patients. We can see here ACE inhibitors are not associated with a higher infection rate of the disease. And so the same conditions also happens to ARB, ACI inhibitors, beta blockers, calcium channel blockers. None of the medications treated for hypertension are associated with a higher rate for infected by the virus. So we can see another paper published further. This paper was carried out in a population-based case control study in Italy. A total of 6,000 patients, around 6,000 patients with SARS-CoV infection was confirmed between February and March. And after the enrollment of the patients, they also enrolled another control group from the same area. And they tend to match the cases and the controls and do another analysis. We can see here, after adjusted for the possible risk factors, again, AC inhibitors, ARB, calcium channel blockers, beta blockers, all the possible GDMT components are not associated with a higher rate of infections with the disease. So that may imply that we can keep using our GDMT therapy. And as I have mentioned earlier, perhaps we can be more aggressive in prescribing these medications, because we need to control the patients in a better condition so that they won't be prone to be infected by the virus. So another possible hint here is loop diuretics are associated with a higher rate. We can see here is possibly significantly that loop diuretics usage are associated with a possible higher rate to be infected by the virus. The experts offered an explanation here that we could not let the patients to be over dehydrated, because if they are over dehydrated, the mucosa are more dry, and they are prone to be invaded by the virus, to have a less weight mucosa or barrier. So if we divided the patients into patients with mild to moderate symptoms and also critical or fatal infected by the virus, and we did the adjustment again, also in these circumstances, in these subgroups, the usage of the medications were not associated with a higher rate to be prone to more severe conditions of the disease. So no matter how we divided the patients, the medications are neutral. They are not easy to be associated with a higher rate of infections of the disease. This is the final paper that to evaluate the possible effect of the cardiovascular disease and their medications. These studies were, again, the studies collected all hospitals all worldwide, including Asia, Europe, North America, and all hospitals. They included around 500 patients who died from the disease, and another 8,000 patients survived to discharge from the disease. And after the adjustment for the factors, they concluded again that coronary artery disease and congestive heart failure are the possibly top 1 or top 2 factors to be associated with the mortality of the disease. So we need to control this disease well, especially in this pandemic era. And the use of AC inhibitors here are not associated with the disease, and even to have a protective role in this analysis. But the authors concluded that we cannot say we are going to prescribe AC inhibitors to prevent patients from the disease, but we can say that the use of AC inhibitors, ARB, or other GDMT therapies are not associated with a higher rate of infections by the disease. So these are the summarize of the opinions from the possible, all the societies. The experts' opinions are simple: just to keep using ACI or ARB or other kinds of GDMT therapy. And some experts also offer an extra opinions that the ARNI have a unique property to prevent patients from higher inflammation rate. So COVID-19 patients may benefit from ARNI therapies if they can get the benefits of anti-inflammatory effect from ARNI. So again, it's also safe to use ARNI for patients with chronic heart failure in this pandemic era, because it has an extra effect to prevent patients from higher inflammations. So another opinion turns to, is SGLT2 inhibitor safe in COVID-19 patients? Because from the previous analysis, we can see here loop diuretics may produce higher rate of higher or severe infections if the patients got infected by the disease, because we do not want the patients to be over dehydrated. SGLT2 inhibitors tend to be violent deletion, and they may cause a little chance to be patients to be hypoglycemia. So if the patients are easily to be over dehydrated by SGLT2 inhibitors, we should be careful about the usage of SGLT2 inhibitors in this pandemic era. So these are the summarized for the treatment of chronic heart failures in current circumstances. We should check BNP, NT-proBNP to monitor the patient conditions for their chronic heart failure. We should monitor the ECG change and the echocardiographic more frequent in this pandemic era to keep the patients in good conditions. And we should keep our guideline-directed medical therapy, especially in these circumstances. And for patients with chronic heart failures, these are the opinions. I will use this table to summarize the talk today. The opinions from the European Society of Cardiology suggested that patients with hypertension or chronic heart failure should receive treatment with ACI ARB despite COVID infection status. And from the opinions from the Canadian Cardiovascular Society also suggested that continuations of ACE inhibitors RNA therapy is strongly recommended even in COVID-19 patients. So nothing need to be changed, but we need to be more aggressive to prescribe our GDMT, and we need to be more aggressive to monitor the patients to keep our chronic heart failure patients in a better conditions so that they can get rid of higher rates of infection. They can get rid of more severe condition of infection. So these are the possible things that we should do currently. We should monitor the patients with biomarkers. We should monitor the patient conditions with a great variety of devices. And we should possibly prescribe the medications by telemedicine or home drug delivery once if the patients are not willing to go to the hospital. We should do more aggressive guideline direct medical therapy, and we should avoid these patients to do hospital visit so frequent to protect them and also to protect the patients in the hospitals. And these are the possible suggestions here. And we should monitor the patients with poor prognosis. We should monitor the patients by biomarkers, and we could prescribe these medications in COVID-19 patients together with chronic heart failure. For SGLT2 inhibitor, we need to be more cautious. We need to monitor the fluid status for patients with chronic heart failure, COVID-19 infection, and if they are using SGLT2 inhibitors, we should monitor their fluid status, not to let them to be over dehydrated. So if we treat the virus, we need to treat our chronic heart failure more aggressively, so that they can get rid of the virus and they can be get more protections under this pandemic era. Thank you, everybody. And this is the above is my talk.
Thanks, Dr. Wu. You covered almost all the ground. I have actually a lot of questions, but we're going to defer that until Julian's talk that combines acute heart failure management during COVID-19. Julian, are you ready?
Yes, I hope so. I'm sorry about that.
No problem. Maybe you can share your slides. That's great.
Can everyone see this?
Yeah, we can see it clearly. Go ahead.
Yeah.
Okay, great. Thank you. So thank you very much to the APSC and to the organizers for inviting me to give this talk. I apologize again for the technical problem. So the topic that I have been tasked to take a look at is the strategy of acute heart failure therapy during the COVID-19 pandemic. And this is a topic I think that doesn't really have a lot of data to go through. So I thought I would frame it in terms of 4 areas that we can look at. And the first is from the patient perspective and the patient reluctance to seek medical attention during the pandemic period. Very briefly, I thought we would like to share some of the experience that we had in terms of pandemic ethics and resource limitations during this time. Thirdly, then we'll then go into the meat of the topic, which is with regards to decompensated heart failure and how we manage it during a COVID-19 pandemic. And more importantly, I guess, is how we sort of distinguish it from ARDS, which is its much more common respiratory manifestation. And finally, I think we'll take a look at this slight oddity, which has been reported in observational literature, where patients with COVID-19 infection tend to have a lot more RV dilatation, RV failure. So by means of introduction, we know that COVID-19 pandemic is a global public health emergency. We know that the complications of COVID-19 mainly involve the respiratory system. Evidence of the association between COVID-19 and cardiovascular complications are still evolving, and they are based on observational data. And I think this is something that's probably worth stopping to re-emphasize. I think sometimes when we have physicians and we have patients who are very anxious to avoid a bad outcome, we can be very subjective to cognitive bias. So this is something that we should be quite mindful of. Cardiovascular involvement is very common in patients who have severe COVID-19 disease. In patients who do not have severe COVID-19 disease, we know that the evidence of cardiac involvement is associated with worse prognosis. The cardiac manifestations in COVID-19 include acute coronary syndrome, include arrhythmias, include heart failure, which is the subject of this talk, and sudden cardiac death. Now, many of these cardiac manifestations are actually very intuitive and are associated with other respiratory viral infections in general. Some oddities have been reported for which further investigation may be helpful. And from a heart failure perspective, that includes this certain preponderance for RV dilatation and RV failure. So first we turn to the patients and their reluctance to seek medical attention. We know that the disease course of heart failure is a chronic progressive illness interspersed with acute, potentially life-threatening deteriorations superimposed on a gradual functional decline. And we know that unlike most solid organ failures, apart from renal failure, it is very difficult to predict which hospitalization is going to end up being the terminal one and leading to a terminal event. So this is very important to the heart failure patients, because when our heart failure patients start viewing the hospitals as COVID-19 repositories, they may potentially delay their presentation to the hospital and therefore turn up more sick. And we have some data showing this now, and that must be concerning from our perspective. Now, this is the data from 9 high-volume primary PCI centers in the United States, and they were just observing the number of PCIs over the different time periods. And you can see that from January to March, the bars in red, there was a drop in primary PCI presentations. And this, of course, coincided with the outbreak of the COVID-19 pandemic in the United States. So there was about a 38% drop in patients who presented to primary PCI centers. And this is very consistent with data that we see in Europe, for example, in Spain, where there's a 40% drop in primary PCI volume. And this is very counterintuitive to what we expect in a pandemic, where because of the viral infection and because of viral triggers, you expect an increase in patients, either due to true acute coronary syndrome or through ACS mimickers such as perimyocarditis. But we don't see this, we see a drop. But that is ACS, and we're talking about heart failure today. So what about data on heart failure? Well, this is, again, another observational audit from the King's College London group. And they showed from the chart in red that there was a very big drop in patients who presented with acute decompensated heart failure to their unit. And this drop was very time concordant with the rise in the daily number of UK COVID cases. If you compare this to a similar time 1 year ago in 2019, you see that the numbers are quite high. So that's one thing to say. So both in heart failure and in acute coronary syndrome, you see a drop in the number of patients presenting to the hospital. But much more worrying, there was a very statistically significant increase in patients who presented to this unit, with more patients in NYHA class 3 to 4 failure, and more patients who had severe peripheral edema. So patients are trying not to come to the hospital and only presenting to the hospital a bit later in the disease course, where interventions have to be a bit more aggressive. So paraphrasing FDR, the fear of the COVID-19 infection is really emerging as a cardiovascular risk factor in itself. So not just the virus as a cardio risk factor, but fear as a cardiovascular risk factor. We know that fear and emotional stress can precipitate acute coronary syndromes, either directly or indirectly. We know that there is evidence of increased rates of ACS and heart failure that will persist for years after catastrophe. And this doesn't just have to be viral infections. Things more recently, such as the New Orleans flooding, corresponded to increased rates of these events years after the catastrophe in itself. We know, based on data from Hong Kong, that the risk of acquiring COVID-19 infection in the hospital setting is estimated to be less than 1%. We know that asymptomatic SARS-CoV infection rates, while currently unconfirmed, are estimated to be about 55 to 70%. And while this case fatality rate was high initially, as consistent with most pandemics, CFR tends to drop as more data becomes available. And the current estimation of case fatality rates for COVID-19 is estimated to be at less than 1%. And so this really cannot be outweighed against the worst clinical outcomes that occur due to avoidance of medical facilities. So this is my final slide on this part of the talk, and it is to highlight a tertiary heart failure unit in Madrid in Spain. And what these guys did was they identified there are 368 patients who they felt were in need of more care. They had 4 specified physicians call these 368 patients, check up on them, make sure they were okay, make sure they're checking their weights and taking their medications. And those who had red flag symptoms were then identified to come back. They were given verbal advice. If it didn't help, they were identified to come back to the outpatient clinic, the outpatient setting, and therapy had to be, they could do tests and administer IV diuretic therapy, and they were followed up. And by doing this, they showed that the heart failure admissions dropped by about 45% and ED presentations dropped by 55%. And now with the knowledge of what's been happening worldwide, it might be difficult to say that this intervention resulted in the decreased number of presentations to the hospital. But nevertheless, this is the first paper that I came across where the heart failure unit was so aggressive in using telemedicine to actively reach out to their patients. And I think they should be applauded for this event. Of note, only 4 out of 368 of their patients, which is 0.01%, eventually ended up being diagnosed with COVID-19 at the time of publication of the paper. So I think that intervention certainly helps some in a group of patients who are certainly at higher risk. I've only got 2 slides on this topic, which is pandemic ethics. And this is really, I suppose, just to share our experience that we had in Singapore. And I'm not sure whether most of the audience is familiar with what happened in Singapore, but I think things were largely under control for a very long period, for a short while, until we had a sort of a disease outbreak in our foreign worker dormitories. And then our numbers started getting quite large quite quickly. And there was a lot of concern within the medical community as to whether we had enough ICU beds for all the patients. And that forced us to sit down and discuss some very difficult questions and some very uncomfortable questions. And I guess that's what we do in Singapore. We like to plan for things, and things don't always materialize, but we like to sit down and plan for it nevertheless. But some of the difficult questions that we were sort of asking ourselves is sort of the role of nationality, whether in the event when push came to shove, would we be comfortable with prioritizing Singaporean patients over foreign patients? Questions such as, would we prioritize patients who were paying class patients who came from abroad specifically for medical treatment? Or would they be any different from a foreign worker who was working in Singapore who could not afford his medical care, for example? The second question was with regards to reciprocity. In the event that someone was a healthcare worker, did their healthcare worker status therefore give them a sort of a, should they then be prioritized for an ICU bed? And the concept behind that, of course, is if we could nurse them back to health, they could come back and contribute to the fight against the COVID-19 outbreak. And for those who felt that healthcare workers should not be prioritized, would it be any different, for example, if this was a retired physician or a retired healthcare worker who had come back to help during a pandemic time because the healthcare system was overwhelmed? Should they not be prioritized for an ICU bed? So that was the second question we asked ourselves. And the third question is, how much should bad social responsibility decrease your chances of getting an ICU bed? For example, if you were socially irresponsible, you didn't wear your mask, you were going out for events, non-socially distanced events, would that decrease your chances of getting an ICU bed? So these were some of the questions we explored at this time when we were concerned about whether we could get the ICU bed. So in terms of triage and pandemic ethics, it really follows the triage that we have in our regular ICU care. There should be very explicit, there's a 3-step model. The first step really is we should have very explicit inclusion and exclusion criteria. After that, if a patient was included and was going to need an ICU bed, then we needed to have a prioritization system, which ideally should be data-driven. It should be multidimensional. And sometimes in the event of all things being equal, Things like age may end up being a tiebreaker. And finally, as with most cases in ICU systems, the third step is assessment and reassessment. And really, sometimes the best way to check if a patient will respond to ICU care is to give them a time-limited duration of ICU care, with the understanding for the patient and the family that if they did not respond to the treatment, then there would be a rapid transition to a more palliative paradigm. Okay, so now we come to the meat of the topic, which is acute heart failure and how these patients present. So we know that there are, broadly speaking, there are 3 stages to the infection in COVID-19 with SARS-CoV-2. And the 3 stages include early viral response, where you expect some coryzal symptoms, there's a lymphopenia. It moves very quickly to the stage 2 pulmonary phase, and hopefully it stops there, where you get some pulmonary symptoms. And finally, stage 3 involves hyperinflammation and the cytokine storm, where the host response becomes more dangerous than the virus itself. We know that the leading cause of death from COVID-19 is really respiratory failure from ARDS. And we know from very early data in both the UK and in New York that once you require invasive mechanical ventilation, your mortality rates range from 50 to 90%, which is quite high. Other common complications in patients who had died include myocardial, liver, and kidney injury, as well as multi-organ dysfunction. Specifically for the heart, though, we know that viruses such as influenza and viruses such as Coxsackie have direct damage toxic effects to the myocardium and can cause myocarditis. We know in B on the right, viruses such as influenza can have acute plaque destabilization effects and can precipitate acute coronary syndrome. But any virus in general with stress can increase your risk of ACS, and we believe SARS-CoV-2 is the same. Third, we talk about stress cardiomyopathy, which can occur in any virus. Specific to COVID-19, the role of the microvascular circulation becomes important. And we talk about the role of endothelialitis. We talk about microthrombi in the vascular endothelium, which increase your risk of coronary events. And finally, E is the role of cytokine storm and the hyperinflammatory response that causes more systemic effects. So these are really the 5 mechanisms from which we think that COVID-19 affects the heart. I'm going to spend a bit more time on this slide, but I think it's a slide that's very familiar to a lot of people. This is generally how we manage acute decompensated heart failure contemporarily. And this is based on a lot of registry data that we obtained in between 2000 to 2010, I think. And essentially, we divide them into forward and backward failure. The majority, 66% of all patients who present an acute decompensated heart failure are wet and warm, meaning they have preserved forward function, but they are congested and therefore they are wet. And when all things being equal, when they're wet and warm, we then fall back to adhere registry data where we look at whether blood pressure becomes important. When hypertension predominates, vasodilators have to take effect because we know that the failing left ventricle is very afterload sensitive. Therefore, if they're hypertensive, we should preferentially vasodilate and then decongest. If congestion predominates, then we diurese first and we use vasodilators if the blood pressure allows. So that's the majority, 66% of the patients who are wet and warm. If you are in the other extreme end of the spectrum, where you have problems with both forward and backward failure and you're wet and cold, this is 10% of patients who come in acute decompensated heart failure, and this is the one that is associated with the worst prognosis. Again, we fall back to the blood pressure. If the blood pressure is low, we go to inodilators, and inotrope increases your cardiac function, although this is associated with increased mortality, but needs must, you're hypotensive, you're getting organ hypoperfusion, you have to give an inotropic agent, and you vasodilate as the blood pressure allows. In the event that you come in mixed shock or you come in late, where you have hyperlactatemia and some vasoplegia, then a vasopressor may be needed, in which case noradrenaline is your first choice vasopressor. If your systolic blood pressure allows, then vasodilators are first choice, followed by diuretics and inotropes if necessary, because as we mentioned, inotropes are associated with increased risk of mortality. So this is the broad framework of how we manage acute decompensated heart failure. And it's something that I think is very familiar to a lot of us. And I just bring it up as a refresher, and really to say that I haven't seen anything from any observational data or any data in general to say that treatment of acute decompensated heart failure in COVID is any different from how we practice at the moment. So I suppose the main thing that came to my mind was really how do we differentiate cardiogenic acute pulmonary edema from non-cardiogenic pulmonary edema, which is acute respiratory distress syndrome. And of course, the answer to that really is based on hemodynamic data we obtained in MI data sets. And in non-cardiogenic pulmonary edema, it is defined when your wedge pressure is not elevated. And generally, we take a cutoff of 18 millimeters of 18 millimeters. Of course, ARDS is a common cause of non-cardiogenic APO, but other causes of non-cardiogenic APO are present, and we should think of these as well. I'm going to take some time to talk about ARDS because it appears as though the ARDS that occurs in COVID-19 is slightly different, can be slightly different from our traditional understanding of ARDS. So our understanding of ARDS, of course, is framed by the 2012 Berlin criteria and consists mainly of 4 components. It needs to be acute in onset, less than or equal to 1 week. There is usually bilateral opacities consistent with APO present on radiological imaging, either on CT or rhontography. The PF ratio is generally less than 300 milligrams with a minimum of 5 centimeters of water on PEEP, and it cannot be fully explained by cardiac failure. As we said, the wedge should be less than 18. It is further subclassified into mild, moderate, and severe based on the PF ratio. This classification has its critics and has been criticized, but it corresponds to mortality. But the important thing to remember about ARDS is that there are 2 features of characteristics of ARDS. One is you have reduced aerated lung, what we call baby lung. And this can be managed with PEEP, recruiting maneuvers, and prone ventilation. And the second part is low respiratory compliance or stiff lung, in which case you use low tidal volumes and permissive hypercapnia to prevent ventilator lung injury. And this is one of the few treatments in the ICU literature that has actually been proven to decrease mortality. And there are very few things that have been shown to decrease mortality in the ICU literature, but this is definitely one of them. The reason I focus on ARDS a bit is because the Acard's phenotype has been described by the Italians, where they notice an L phenotype of ARDS that seems to be very similar to the PCP phenotype in members with retroviral disease. And in the L phenotype, which is early in the disease, they notice low elastance or normal compliance. They notice a low VQ ratio. They notice low lung weight based on CT imaging. There's a very minimal ground glass opacities, and they tend to be located subpleurally. And there is very low lung recruitability because the amount of non-aerated tissue is low. And so in this group of patients, the Italians felt that vasoplegia was what accounted for the hypoxemia, and they recommended increased minute ventilation and to target low PCO2 was okay. And this runs very counter to our traditional understanding of ARDS, where we would want to decrease the minute ventilation and allow permissive hypercapnia. They did say, however, that with time, the L phenotype would eventually progress to the H phenotype, which is more like our traditional understanding of ARDS. Just to mention very briefly that the intensive care societies of both Europe and America recommend high-flow nasal cannula over non-invasive positive pressure ventilation in the event that they develop acute hypoxemic respiratory failure. So just a quick update on that. And generally the target based on the lung safe registry is a PF ratio of less than 150. And if the PF ratio is less than 150, then you don't really want to try non-invasive ventilation and you really want to consider intubation. And this is very consistent. This was the recommendation from the Chinese Anesthesiology Task Force when they first came up with their recommendations. So some of the counterpoints to early intubation really is that, as with most viral respiratory infections, they tend to resolve at some point, and it tends to be about a 2-week course of mechanical ventilation. And because they have a fixed duration of mechanical ventilation, the postulation is that an early intubation strategy may actually result in more ventilated days versus a delayed approach. And this stems from the observation that SARS-CoV-2 ARDS has a phenotype of the happy hypoxic, where although they are very profoundly hypoxemic, the SpO2 is less than 80%, they present with little or no clinical distress and with no hemodynamic effects, and they are not in tachycardia. So this is an argument against it. For us in the National Heart Center, we really have not observed this L phenotype of COVID ARDS on our side, and we have not really observe the happy hypoxic phenotype either. So we prefer to intubate early in patients with COVID ARDS, and we sort of follow, we prefer early intubation. So I fall back to what I talked about at the start of how we manage acute decompensated heart failure. It is really unchanged from our management of acute decompensated heart failure in non-pandemic times. We've discussed the role of APO, how to differentiate the cardiac APO from non-cardiogenic APO. And the only one last thing I'll mention in our management of ADHF really is that apart from managing the case, we have to go and look back for factors that triggered the acute heart failure and target that as well. So sorry, I think I'm running out of time, but I'm going to talk about RV failure very briefly and just to highlight two things. So the first thing is this paper by the Italians who took a look at, this is a paper from the US in New York, and they looked at 105 consecutive patients, and they noticed that a lot of these patients had RV dilatation. This was a single linear view on echocardiogram, followed by visual inspection of the RV by the echocardiographer. And generally what they showed was that 32 out of the 105 patients had RV dilatation. And the thing that most likely predicted RV dilatation was renal dysfunction. And they showed of these 30 patients, 10 of them had CTPAs done because there's a high risk of VTE in COVID patients. And yet out of these 10 patients who had it, only 5 of them had PE. So VTE was not, well, based on this very small sample size and observational data, the PE did not seem to be able to account for the RV enlargement in itself. Out of these 100 patients, 21 patients died. And of all the on multivariate analysis, the RV enlargement was the only variable that was significantly associated with mortality. So a very interesting paper, observational study of 100 patients. This was a paper in China after that, and this looked at patients who essentially had very mild symptoms of COVID-19. Some of them were housed at home. They did not go into the hospital at all, but because of various cardiac symptoms, they had a cardiac MRI done, and they showed that the EF and the stroke volume of the patients with COVID-19 compared to controls had lower RV systolic functions and lower RV stroke volumes. So what is the cause of this RV dilatation and decreased RV systolic function? Well, the mechanism is really unknown. It may include thrombotic events. It may include hypoxemic vasoconstriction. It may be due to the cytokine storm and hyperinflammation, and it could be due to direct viral damage. We are really not sure. I might skip this if that's okay. So we talked about how the failing left ventricle was very afterload sensitive. Well, the RV in itself is even more afterload sensitive than the failing left ventricle. So we really have to try to decrease RV pressure as much as we can. And we can consider things like IV milrinone, which is what we use in our unit, apart from levosimendan in patients with RV failure. But there really is no good treatment for RV failure that we know of. So just something to look out for if your patient comes in with cardiac complications of COVID-19. Sorry, in conclusion, cardiovascular involvement is common with severe COVID-19 disease and is associated with elevated risks of mortality. Heart failure rates are anticipated to increase and persist for a sustained period of time, even after the pandemic ends. If heart failure presentations have decreased in your unit, you might want to consider reaching out to your patients via telehealth, and that might help to decrease the risk of your patients from catching COVID-19, especially as they are a very vulnerable group. The mortality from COVID-19 disease is largely due to hypoxemic respiratory failure from ARDS. The principles of management in ADHF remain largely unchanged, and the observational reports of RV dilatation warrants further evaluation, and it's something to look out for when we manage these cases. I was just going to end off with this slide, which was recently published in JAMA. And essentially, it was based on 2 papers in Germany. If you look at the extreme right, on a case series of 39 autopsy studies, they found SARS-CoV in the heart. But interestingly enough, they didn't find it in the myocardium. Remember, we talked about influenza and Coxsackie and how it can have direct myocardial toxicity. Well, the SARS-CoV seems to be more in the interstitium and in the macrophages rather than directly invading the myocytes itself. And if we look at MRI studies of patients who have had COVID-19 with very minimal symptoms, very well COVID patients, they actually have some degree of late gadolinium enhancement and scar tissue, which is quite concerning. And so Professors Clyde Yancey and Greg Fonarow, who are very esteemed members of the heart failure community, postulated that after this coronavirus ends, we may see a spike in our incident heart failure patients. So just something to think about.
Thanks,
so with that,
Thanks, Julian. Thanks for keeping the time. Maybe overran by a little bit into our Q&A time. Maybe I'll ask you to stop share. So we're going to take a quick pause. I think we don't have much time for Q&A session. So maybe the two lectures covered so much ground. There's so much questions there, but maybe I'll just focus to two. One question I'd like to ask Dr. Wu is, we really want to do the best guideline. Do case or isn't it, Dr. Wu? Dr. Wu?
I'm sorry.
Can you repeat the question again?
Yeah, so for patients who present with acute heart failure, do you, and they are de novo acute heart failure, is there any concern with starting a ACE inhibitor or ARB with regards to this conversation about spike protein ACE2 receptor issue?
Thank you for the very important questions. Actually, we are just discussing these questions with Professor Lin just before this question. According to current guideline for chronic heart failure patients who are receiving ACE inhibitors or ARB, because we cannot see any evidence that using the medication is associated with severe or higher incidence of infections. So the guideline just suggests keep using the ACE inhibitors, even there's a possibilities of higher expressions of the ACE2 receptors. But for patients with acute infections or acute heart failures, we should be cautious about the using of ACE inhibitors if he has active symptoms of coughing, because we are afraid that the spread of the virus could be more serious even for patients who receive ACE inhibitors in these circumstances. Perhaps if patients with acute heart failure and we are prescribing the medications, ARB may be a better choice for patients with acute heart failure and the first exposure to this kind of medication.
So I think there are ongoing trials to clarify this issue, even trials randomizing to treat with ARB to see whether it helps even SARS-CoV-2 infection or makes it worse. So I think it's a good suggestion by Dr. Wu. Maybe the last question before we move on the lecture, I'd like to ask Dr. Yeo Koon Keong. We heard from both speakers about this disappearing, whether ACS or acute heart failure attendance. And I heard Professor Barbara Cassidy over the weekend spoke about mortality rate increase in their EMR data search in UK over this period. There is after discounting direct mortality from SARS-CoV, there is still excess in mortality that is postulated due to decreased attendance to acute conditions like NCDs or ACS and heart failure. Do you see this data trend across the region or in Singapore, Dr. Yeo?
So thanks very much, Jack, and to the two speakers for very, very cogent discussion. With regards to your question on whether or not we see a sudden death or unexplained or death from other causes, well, we haven't seen that data coming out of Singapore. There is an ongoing national level study to explore that, where we will look not just at mortality data from COVID positive patients, but also in those in the general population who may or may not have been diagnosed with COVID. I think perhaps a country like Singapore, and I suspect in those countries where there is nationalized healthcare, we might be able to get that data because first of all, Singapore is really kind of small. So we do have a pretty robust system of capturing that data. So I'm hoping that we will be able to answer that question soon. But right now, in terms of signals, at least within the few public hospitals, we don't have that data. We haven't seen that signal.
Thanks. I think Taiwan is fortunate in not having a lot of cases. Their national registry is also pretty solid. So we'll hope to see more data coming out of Taiwan as well. So with that, I think we need to end the Q&A to move on to the next segment. We'll ask Professor Lin to introduce the next speaker.
Okay, I'll introduce the third speaker of this webinar. The third speaker is Dr. Masafumi Kitakaze. Professor Kitakaze is currently the director of the Hanwha Daini Senboku Hospital in Osaka. He is also the invited professor of Osaka University Graduate School of Medicine. Professor Kitakaze's main interest is in basic and clinical research in hypertension, heart failure, and integrative physiology. He is also quite famous in AV cardiovascular field. So he is currently editorial board member of Circulation, Journal of Molecular Cellular Cardiology, Cardiovascular Research, Basic Research in Cardiology, and also in American Journal of Physiology, Hypertension Research, etc. Today, the Professor Kitakaze is going to give us a talk talking about the biomarker guidance of acute and chronic heart failure therapy during COVID-19 pandemic. Professor Kitakaze, please.
Thank you very much, Professor Lin, and thank you very much for the organized committees. Today, I will talk about the biomarker guideline of acute and chronic heart failure therapy during COVID-19 pandemic, but my talk will not be relevant to the COVID-19 pandemic situation, but I believe that the biomarker guideline is also realized in the COVID-19 pandemic situations. So I used to be in a National Cardiovascular Center, but recently I moved to the Hanwha Daini Senboku Hospital, and we have almost 1,000 beds, not targeted in not only the cardiovascular diseases but also general diseases as well. So this is my COI. And also, what the major biomarker to detect the severity of the heart failure? That's a very important question. So we follow up 225 patients with heart failure who were hospitalized for the worsening of heart failure between 2008 and 2009 until April 2011. After the discharge of these acute heart failure patients, we examined the relationship between more than 400 clinical parameters and the cardiovascular event of CV death or rehospitalization for the worsening of heart failure. This study was done by Professor Dr. Chen in Mackay Medical School, who came to National Cardiovascular Center for the research. And we found that the BUN and the BNP and the decreases in diastolic blood pressure largely affect the incidence of rehospitalization for the worsening of heart failure. And the cutoff point on the BUN is 22.5 and the BNP 250, diastolic blood pressure less than 60. So this situation looks like biomarker for the chronic heart failure and for the prognosis or cardiovascular event in the future. So plasma BNP levels increases the plasma BNP levels, serum BUN levels, and decreases in diastolic blood pressure, the kind of very important biomarker for detect the progression of heart failure. So first, I'll talk about the BNP levels. We'll focus on the plasma BNP levels because BNP is produced in the myocardium, suggesting that BNP may reflect the severity of myocardial damages. Of course, increases the prevalence afterward, increases in the LV dilatation or decreases the LV wall thickness. All of these factors are related to the increase of the BNP levels. So BNP is thought to be the function of myocardial shear stress. When it increases the myocardial shear stress, that increases BNP because BNP upstream of the BNP gene, we found that the myocardial stress shear element in the upstream. So BNP might be sensitive to the myocardial shear stresses. So actually, in the heart failure progresses, BNP levels increase like this. This is a kind of a common sense for the cardiologist. And also BNP less than 170 or more than 170, we found that this is not our study, but a Japanese study showed that the increases in the BNP levels worsen the severity of the heart failure in a Kaplan-Meier analysis. So recently, we found the curious findings regarding the plasma BNP levels. Actually, 10 years ago, we performed the ABC study. ABC study is a prospective randomized open blinded endpoint study to test the effect of an alpha glucosidase inhibitor, Voglibos, on cardiovascular event in myocardial infarction patient with impaired glucose tolerance. So all the MI plus IGT, for such a patient, Voglibos might affect the cardiovascular outcomes. Primary endpoint is composite endpoint, cardiovascular death, non-fatal MI, non-fatal unstable angina, PCI or CABG. And the secondary endpoint is individual factors of the primary endpoint. And variables group in the 400, control group is more than 430. And 75 gram OGTT at the 2 hours of blood glucose, that variables improved 164 to 139. So it improves very much. But the Kaplan-Meier analysis showed the variables has no effect in the composite endpoint of in patient of all the myocardial infarction. So we investigate what factors are most important and influential to affect the cardiovascular event in patients with old MI and IGT. We try to use artificial intelligence, AI, to find the hidden factors. Using the limitless RT multiple testing procedure, we call that the LAMP, an artificial intelligence AI-based data mining method, we analyzed 385,391 combinations of fewer than 4 clinical parameters. So it's a very huge analysis. And 853 patients using the 43 parameters. The target function is all-cause hospitalization, hospitalization due to worsening of heart failure, non-fatal MI, PCI, or CABG. We tested the combination, the 385,391 combinations. And we pick up, for example, all-cause hospitalization, we pick up the 171 combinations, hospitalization due to worsening the heart failure, 176, hospitalization due to non-fatal MI, 16, CABG or PCI, 70 combination. We further analyzed what factor is most important, and we found that for the all-cause hospitalization, BNP or use of diuretics is a very important factor to detect the all-cause hospitalization, heart failure, also BNP and diuretics. These are kind of common sense, but the interesting issue is non-fatal MI is also detected by BNP, or PCI or CABG is also detected by high BNP levels. Of course, BNP is released from myocardium, not from the coronary artery, but the MI or PCI can be predicted by BNP levels. We check that the Kaplan-Meier analysis because we use a LAMP method, a very new AI method. This is a kind of a new method. So we would like to check that in the Kaplan-Meier analysis is a kind of a traditional analysis. We found that the high BNP level increases all-cause hospitalization and hospitalization due to worsening of the heart failure. Not only these things, PCI or CABG, for stable angina or non-fatal MI is also is a function of BNP levels. So in patients with old MI and IGT, high plasma BNP level predicted cardiovascular event, such as the occurrence of non-fatal MI or heart failure in MI patient with IGT. But interestingly, the high plasma BNP level predicted the occurrence of significant coronary stenosis. We also demonstrate the use of AI in cardiovascular medicine because when coronary artery stenosis progresses, that burden the myocardium, that impair the myocardium, that increases the BNP level. So this is a kind of an indirect biomarker for coronary event in a patient of heart failure. So next question, do the plasma BNP level predict the coronary event in addition to the heart failure related event? So we check that in a cohort study. We have worked in a cohort study in the Kyushu area, Kyushu Aitacho area. Aitacho is famous for the pottery, Japanese pottery, and we follow up in 1,530 population, men and women like this ratio. And we check the BNP level in this cohort. BNP level, the median BNP level is 18.9. So they are quite healthy. There's no heart failure patient in the Aitacho study. But interesting issue, the men and women, when a BNP level increases, low BNP, middle BNP, high BNP, the coronary artery risk is very much increased. So BNP can predict the coronary artery risk in a men and women like this. So high plasma BNP levels may predict the existence of coronary artery diseases. This would be the new finding for the use of the BNP. And the next issue is serum BNP, BUN levels. We will focus on the renal function because cardiorenal syndrome suggests the linkage between the renal and cardiac functions. And we focus on the FGF23 because serum FGF23 increases renal function decreases in a CKD patient. And FGF23 is a hormone that controls plasma PI homeostasis. But interestingly, in the basic study, FGF23 is proved to cause cardiac hypertrophy. In the clinical study, serum FGF23 levels are related to cardiovascular hypertrophy in progressive CKD patient. So FGF23 renal function is a kind of a biomarker for the heart failure. So that might be reflected to the FGF23. So we check the FGF23 level in the heart failure population that increases FGF23 level increases in the heart failure patient. We check that FGF23 in a normal EGF population in the healthy and the heart failure population. And also we performed the multivariate analysis. We found that EGFR is also related to the FGF23, but PI level is also related to the FGF23. But independent of these factors, existence of the heart failure also predicted a high level of FGF23. And we checked the relationship FGF23 and the cardiac function. Cardiac index is also related to FGF23, and LVEF is also related to FGF23, like this. And we check the cutoff point. We check the cutoff point. We observe the cutoff point in 49.4. And we use this value in high and low, separated high and low. We found that the cardiovascular event is very much high in the high FGF23 group in patients of heart failure. And we performed the biopsy in such patient. And we checked the high FGF23, low FGF23 groups. We found the myocardial fibrosis is very much different in this population. But the cardiac hypertrophy, the main diameter of cardiomyocyte or area of cardiomyocyte are not linked each other in the low and the high FGF23 levels. So we believe that the FGF23 works for the promote myocardial fibrosis in the patient for heart failure. So high plasma FGF23 levels may become the biomarker of heart failure because although FGF23 is generated by bone and works for the renal function, but in the same time, FGF23 it also affects the cardiovascular event or cardiovascular physiology. So next question is, what is the difference from the viewpoint of understanding of the pathophysiology of heart failure between blood BNP and FGF23 levels? Are they same or different? And we checked right-sided heart failure index. This is a IVC index. IVC is a index of the right side of the heart failure. BNP does not relate to the IVC levels, but FGF23 is related to the IVC levels or respiratory changes. BNP is not related to these differences, but FGF23 is related to these changes. So FGF23 is also the biomarker for the right-sided heart failure. So, and also we checked the RA pressure. RA pressure is also index of the right-sided heart failure. BNP does not affect the right-sided heart failure, right arterial pressure, but FGF23 is related to the right arterial pressures, RA pressures like this. And we also checked the FGF23 in multivariate analysis, and we found the bilirubin, AST, sodium, BUN, EGFR, and urinary blood. These are kind of a function of FGF23 levels. So right-sided heart failure is very much predicted by FGF23 levels. And how about the left-sided heart failure? And the BNP FGF23, both are related to the wedge pressure or cardiac index. So BNP is, of course, is a function of the right-sided heart failure. And FGF23 is also as well right-sided heart failure, left-sided heart failure is also affected by FGF23 levels. So BNP is a kind of a left-sided heart failure. FGF23 is a both-sided heart failure biomarker. And also, of course, cardiovascular event is also predicted by BNP or FGF23 independently. So BNP levels, BUN levels is a reflection of FGF23. The last issue is the diastolic blood pressure. We'll focus on the diastolic blood pressure. And this is not our study, it's Circulation 2001, and the high age population in coronary heart disease is predicted by high level of diastolic blood pressure. That means the low diastolic blood pressure worsens of the coronary heart diseases like this in a high age population. So low diastolic blood pressure might be the index of atherosclerosis. And there the documentation in 2020 papers show that the decreases in the diastolic blood pressure reflect the severity of aortic atherosclerosis and less arterial compliance via the increases in the speed of reflection wave. So what happened when myocardial arterial compliance decreases? Compliance decreases means atherosclerosis. When compliance decreases, ejection timing gets earlier like this. So ejection timing gets earlier. What happened to the myocardium? We performed this kind of study. This is a volume, LV volume. This is the time. And this is the end diastolic volume and the systolic volume. Ejection timing is just related change like this. So early onset of ejection decreases relaxation speed. T is a relaxation time constant. So high time constant means low speed of relaxation. So early onset of the ejection decreases the relaxation speed. That might cause diastolic heart failure, so-called HFpEF, heart failure preserved ejection fraction. So aortic elastance decreases, causes HFpEF condition. So today's my talk is plasma BNP levels, serum BNP levels, and diastolic blood pressure level is a very important factor for the biomarker for worsening of heart failure. Plasma BNP is the index of cardiac function. Serum BNP is a kind of a renal function, and also decreases the diastolic blood pressure is a vascular function. So this function is very important to think about the progression of heart failure. So this is my colleagues here. Thank you very much for your kind attention.
Thank you, Professor. I think in the interest of time, we'll move on to the last lecture first before Q&A.
Sure. Okay,
thank you.
Of course. Thank you.
Professor Lin, you want to introduce the last speaker? Are you muted, Professor Lin? Maybe you can unmute yourself.
Okay, you're saying now.
Yeah,
Yes.
now you're okay.
Okay, it's okay now. Okay. The last speaker is Dr. Bijoy Rajbanji from Nepal. Currently, Dr. Rajbanji is the principal consultant and head of the Department of Cardiovascular and Thoracic Surgery at Nepal Medicity in Nalipur in Nepal. He is a cardiac surgeon. He is particularly majorly in the aortic surgery, and he had been clinical fellow at the Mayo Clinic and also advanced clinical fellow in the New Haven Heart Center, and they focus on the aortic surgery. And today, Dr. Rajbanji is going to give us the talk. The title is The Role of Cardiovascular Surgeon in the Management of Acute and Chronic Heart Failure. Dr. Rajbanji, please. It's okay.
Yeah. Can you hear me?
Yes, we can hear you.
We can hear you. Please go ahead, Bijoy.
Yes. Thank you, Professor Lee. I'd like to thank APSC as well as the organizer of this webinar for involving me. And the topic assigned to me as a cardiovascular surgeon is the management of acute and chronic heart failure. I'm sorry, I'm having a little bit of problems.
I think it's yeah, great.
So I think our previous speakers have mentioned well about the heart failure, and we do understand it's a staggering burden for all of us, whether it's utilization of our hospital resources or the economic burden. And there's data from US which shows extensive uh, around 5 million people in heart failure with a major cost burden to them. Now, what I believe is basically the prevalence of heart failure in general is because as the global world ages, the numbers are going to increase. And I think the second part is the improvement in medical therapy. We've declining mortality for various heart diseases. We've advanced in therapeutics that allows patients to survive catastrophic events that maybe would have occurred in 20 or 30 years down. And based on my previous speaker, I think I could add COVID to this as well. So the therapeutic options are wide range from stage A to stage D heart failure. I think the role of a surgeon is mainly in stage C and D, which comprises of revascularization or valve surgery. And then secondly would be use of mechanical circulatory support. So if I was to summarize a surgeon's role in heart failure, I would put it as a reparative. So different forms of reparative surgery, CABGs, valve repair or replacement, corrective surgeries, even for congenital heart disease, aortic dissections, hypertrophic cardiomyopathy, and complications of MI. In cardiogenic shock would be mainly use of mechanical circulatory support. There are variable number of circulatory supports available. And then as a replacement therapy, which could be partial or full, using the ventricular assist device or transplant. Coming to the acute heart failure, I think we all know that the presentation is variable. Patients could present in catastrophic shock requiring even cardiopulmonary resuscitation. In acute severe shock where time becomes an important factor and you want to restore the cardiac output as earliest as possible. And then again, these patients moving into a progressive shock and where also then it becomes important. And then as they go into chronicity, you would look at putting in mechanical circulatory support. So with acute heart failure, if you just look at this flow diagram, so with the medical management, there would be a strategy for involvement of a surgeon when it comes to reperfusion, especially with regards to CABG. And then if the recovery doesn't occur, if there are other conditions, then we would be involved in a placement of mechanical circulatory support, basically starting it as a temporary. And then if the recovery does not occur, then we would progress to a more durable ventricular assist device, which could be used as a destination therapy or as a bridge to transplant. Now, just briefly gonna go over the different surgical options here. I'll just breeze through them because there are multiple. So I think one of the most important would be coronary artery bypass grafting. And one of the seminal papers with this would be the Stitch trial. I think some of the panelists here have been involved with this. And what they did was they took patients with heart failure and with ejection fraction less than 35 and randomized them into patients receiving medical therapy versus patients undergoing CABG along with medical therapy. And what they did find was, and these patients were followed in the initial review for a period of 2 years where these patients were reassessed. And though the initial review did not show any significant survival benefit with CABG, but there was a tendency towards towards CABG being more favorable over a longer period of time. And the reason why I put this forth is I think what is important is whenever we do a surgical procedure, especially a cardiac surgical procedure, heart failure becomes a very important and an independent predictor. Just as this in the Society of Thoracic Surgeons risk model, if you were to take a 70 years old male and with a normal EF, the risk would be at least 3 or 4 times less than a patient with in heart failure or a reduced ejection fraction. And continuing with this study, but what they did find was there was a trend of benefit towards CABG from 6 months, especially for sudden death, and then it progressively improved beyond 24 months. And you could see that there was favor towards prevention of fatal MI deaths. And the another important finding that they did find with this study was that there was a hospitalization benefit with patients who underwent CABG with medical therapy, with less cardiac hospitalization because of cardiac causes, or even due to heart failure. And then recently, now we've had the 10 years follow-up of the STITCH trial, and which shows that there's definitely a survival curve crosses at the 1 year. If you look at the chart on the left lower hand of the corner, and then it definitely crosses at 2 years. And then as the years progress, the graphs diverge and in favor of CABG. And like I mentioned earlier, there was definite benefit with regards to hospitalization, whether it was because of heart failure, other cardiovascular hospitalization. I think with CABG in response to heart failure is important. There are multiple studies, and this is a meta-analysis with, and you can see that Dr. Eleftheriadis from the Yale New Haven group had a similar mortality, but there's definitely survival benefit with regards to CABG even in these sick patients. I think the key with CABG in these patients lies the importance of a viable myocardium. And if you look at this meta-analysis published in the Journal of American College of Cardiology, when they reviewed these patients over a period of 25 months, patients that have a viable myocardium did definitely better compared to the non-viable ones. And this can also be added further by this study, which is published in New England Journal of Medicine, which again shows that patients with undergoing CABG with a viable myocardium always did better than non-viable ones. So if you look at the recommendations, basically the Europeans and the Americans, you can see that CABG is recommended when the heart function is low, or when there's diabetes, or when there's triple vessel disease, extensive triple vessel disease. There was another component of the STITCH trial where they looked at left ventricular reconstruction. So what this applies is the infarct non-viable myocardium was incised and a patch was placed within it so that you excluded the infarct segment. And what the thought process was it would remove wall stress, it will decrease the end systolic volume, and possibility decrease mitral insufficiency, as well as eliminate residual ischemia. So there was this arm of the study that was also done with the STITCH trial, and though it wasn't found to be very significant between CABG versus CABG plus SVR, there was a decrease in angina symptoms as well as heart failure symptoms in the SVR group. Now I move on to the next part of my talk on valvular heart disease, and it's predominantly mitral valve regurgitation. What we do understand is as the heart fails, the LV geometry is altered, the ventricles dilate, the annulus expands, there's tethering of the chordae, and what this does is impairs leaflet cooptation, and there's increased left ventricular workload and causing mitral insufficiency, and this again causes more symptoms of heart failure and reduction in LVEF. And what we again through literature know that patients in heart failure with severe MR tend to do much worse than patients without MR. Now for a surgeon, the dilemma with these patients is these are high-risk patients. So we do tend to debate whether we should operate or not, whether repairing the valve or replacement would be a better option. There are several studies, I won't go into details with that. There is a worry that we would leave a residual MR when we repair these valves, and in view of the severe LV dysfunction, what impact it would have. So these are fields that we are still learning from, whether just handling the annulus and reducing the annulus would be enough. And now there are a lot of studies coming up with where you tackle the leaflets, the chordae, the papillary muscles. So I've just briefly highlighted this, and just to add, put this into perspective, if you look at this, excuse me, by Bowling from University of Michigan, they downsized the annulus by 2 sizes, and what they found was that the cardiac output did improve. Sorry. So if you would look at the indications of these patients with mitral valve regurgitation, it is well recommended that we tackle them when the myocardium is viable, and even tackle them when myocardium is not viable, but they have severe MR, but the EF of more than 30%, because below that would be a more higher risk surgery. Moving on to the aortic valve, it's similar. When you get a patient with heart failure with severe aortic stenosis, they would be an indication, and also for aortic valve regurgitation. Now, moving on to another important part that a surgeon has a role in are the mechanical circulatory devices. There are multiple devices. There are the left ventricular devices, right ventricular devices. I'm not going to go into detail, but I think what is important with these mechanical circulatory support is to have a heart team approach, whether we would like to call it as a shock team or a heart team. And it's important that we catch these patients early and have a combined approach on how we handle them. There are various devices. I think I won't go into too much of details with them. The tandem heart commonly can be placed easily in the catheterization lab, as well as the impeller. And then now you have the impeller for the right side as well. Moving on, the extracorporeal membrane oxygenation is more or less of a mini heart-lung machine, which comprises of a membrane oxygenator and a heart pump. And I just recently looked at the ELSO registry, and what I found was that worldwide, almost more than 130,000 have been placed, and for cardiac, around 27,000 over a period of slightly more than a year. And the second table is for Asia Pacific region. So we do almost around 15% of the ECMO runs worldwide, and with reasonable results compared to the rest of the world. And this ECMO has been used in COVID as well, slightly less in our region compared to North America and Europe, and with a reasonable for 55% survival to discharge. There is growing importance of ECMO in cardiopulmonary resuscitation. I think we all know about this. What I want to emphasize is I think now we are even moving into pre-hospital care with ECMO retrieval services. So I think this is a field that is going to continue to grow, and I think the indications are going to progressively change, and maybe we might even have COVID with heart failure involved. And I think the importance of ECMO continues to grow with studies like these, where it's a small number, 12 patients, but they are very, very sick patients, very high Euro score. And these patients required definitive complex procedures, but were very sick and were placed on ECMO as a bridge. And if you look at this, they did complex procedures, and the outcome with it was almost 75% were discharged out following this approach. So I think the role of ECMO is going to continue to grow into procedures like this. And this is another paper that was published a little earlier, where these with patients with acute coronary syndrome were placed on extracorporeal life support and then underwent either PCI or CABG. And these are very sick patients, and we did have a decent hospital survival, although I'm sure as time progresses, we'll start getting better. So I think the further emerging indications with ECMO are going to be, even with these percutaneous valve procedures, even for RV failure, post-LVAD or transplant, and even in pediatrics. Moving on to the ventricular assist devices, I'm not going to go into detail. There are various devices. All these are intracorporeal devices. But what is important, and the growth of this ventricular assist device came from this very important seminal paper, the rematch trial, where patients who were contraindicated for heart transplant were placed either on medical therapy or placed on a left ventricular assist device. And the survival benefit with LVAD was markedly much better. And with time, what we now see is the HeartMate 2 has been converted to HeartMate 3, which is more of a centrifugal flow pump as compared to a previous axial flow pump. And now we are already seeing that these new devices have a survival free for disabling stroke, or as you can see here, though for bleeding, it was not significant, but it's close to significant. And even for changing these devices over a 2 period of years, with the HeartMate 3, it appears to be doing much better. And with that, we start seeing papers like this, where so with these centrifugal flow pumps, the percentage of patients with event-free survival is much better. And I think as technology advances, I think these are fields that we need to keep an eye on. And I think these are things that we could potentially offer patients with chronic heart failure. So with these ventricular assist devices, there are these drive lines that that are attached to the motor, which provides the energy, and it does cause infection. So I think this is an interesting paper which shows basically wireless assists. So I think this is another field that is again going to grow. There is the total artificial heart. In this study, they found that 50% they could convert with biventricular failure to a transplant. There are few studies which show even 75% conversion to transplant. Of course, there are risks involved with these devices. And then moving on to the heart transplant. So over a period of maybe 5 years back, almost 5,000 transplants being done worldwide, but it's predominantly being done in America and in Europe. I think Asia and rest of the world is much smaller in number. But what's again another thing that is important is that it's important that the patients are in a better clinical condition when they go into transplant. So because if a mixed venous, the oxygen consumption level being low, a patient being sick, the survival tends to be much worse. And then if you look at the survival of these patients, and if you would to draw a line at 10 years, it's almost 50% survival. So decent results. If you are younger, then maybe with less more comorbidities and less other organ damages, probably would do better. Just a small point on this. I think these are again things that we need to keep an eye on with regards to heart failure, the cell-based therapy, gene therapy. There's of course a lot of studies going on pharmacogenomics and metabolic modulations. So in summary, there is a definitive role of a cardiovascular surgeon for acute and chronic heart failure. Though as surgeons, we'd like to get involved in everything possible. But just to emphasize, there's role in CABGs, in valve surgery, in remodeling procedure, in ventricular assist devices, and also with regards to heart transplant. So in conclusion, I think heart failure is a very complex disease. There are several surgical options available for patients. And I think a careful patient selection, and I think the way to go forward would be to go in a collective group as a heart team. And of course, we need to keep in mind that there are a lot of state-of-the-art coming up, and as technology advances, and these things have to be kept in mind, and the approach is highly mandatory. I would like to thank you all once again.
Thank you, Bijoy, for a very nice talk. Well, we are just a bit we are perfectly on time. You know, I don't know whether we have time for questions, but perhaps it would be a fitting time to for me to just summarize the 4 talks, and then I suspect we will have to close in order to keep to our program schedule. So again, thanks very much to our co-chairs and the Professor Lin and Professor Jack Tan and our 4 speakers. From our first speaker, Dr. Wu, we heard about the role of guideline-directed medical therapy in heart failure. And specifically, I think Dr. Wu nicely addressed the concerns about ACE and ARB, and I liked his insights as to that perhaps to avoid the possibility of coughing, that we may want to start with ARB. From the sounds of it, with the exception of the notes of concern regarding the SGLT2 inhibitors in COVID patients, we are going to keep to current guideline-directed medical therapy. From Dr. Julian Loh, we heard about the many things, but I note with interest his comments about the ethics of triaging ICU care in patients with COVID, and also the concept of cardiac ARDS. I think that's an interesting notion, which I must say it's the first time I heard of it, so I learned something new, and I'm very grateful for that opportunity. We also heard about the role of the new phenomenon of right heart failure specific to COVID patients, and that area definitely needs more research. From Dr. Kitakaze, we heard about the role of BNP and the FGF23, as well as diastolic blood pressure. I think a lot remains to be seen in terms of how we use this in the COVID arena, whether that is a biomarker that we will need to investigate further in such patients remains to be seen. And lastly, from our cardiac surgeon, Dr. Bijoy, a very strong tour de force on the role of cardiac surgery in heart disease. Some of this perhaps will have a greater importance in COVID patients, especially in ECMO. We have noted in our own experience and the worldwide experience that unlike the SARS from more than 10 years ago, the role of ECMO has been less than we feared in COVID, and maybe that has a bit of impact on our planning as we go along this pandemic. So with that, I'd like to close today's session. I'd like to thank once again Professor Lin for spearheading this wonderful initiative, Professor Jack Tan for his leadership for APSC, and to all our listeners out there, thank you very much. We look forward to sharing more through this platform. Thank you very much.
Thank you. Thank you very much, Professor Lin, co-chairs. Well done. Thank you. Keep safe and goodbye.
Bye-bye.
Bye.
Thank you for your participation. Thank you.
Yep.
Thank you very much.
Thank you.
Okay, we get on the line. Okay.